Hello, this is Matt, trying to see if we can formalize a little bit of our process that we've been going through regarding improving the workflow in our clinic area. We've had multiple meetings already with several of the providers in the clinic, really trying to answer a couple of questions here. Um, those are how can we standardize some of the standard workflow in our systems of clinic with regards to keeping the patient as priority, making sure that their needs are met and that all their questions are answered in good detail to their satisfaction. And then as well, not forgetting our providers who are often left out of this equation, to see if we can help improve the efficiency for which we're working through the system day. We completely realize that different providers are going to be working in different styles that we've all learned. And we also realize that there are systems issues that prevent this from working perfectly. Patients arrive late, for example, or patients need longer visits or second opinion consultation visits. But the general purpose of this flow is to have a starting place, as well as to try to see what an ideal visit might feel like and look like. And so this is really the standard flow, realizing there will be exceptions. Okay, so building on that theme of improving the quality and satisfaction of our system, in this case we're using our clinic workflow in mind, I'd like to get into a little bit more of the fine detail of what that would look like. You will see already posted in our clinic on our bulletin boards is an example of our working document titled The Provider Workflow for GI Clinic. And again, this is a living document that's meant to be changed over time. This is our initial template for that. It's broken up into three broad categories reflecting how we are essentially doing our work. One, as the pre-visit, where we are gathering some information by ourselves before we've even met with the patient. That's often referred to as the prep, and where we really try to develop a little bit of a game plan before even going into the patient room. The second broad category is the actual during visit, where the face-to-face time with the patient is occurring with the provider, and we'll break that down further. And then the last part of the visit is the post-visit, really where we're considering doing the documentation for the visit. So those three broad categories I want to then delve into a little bit more detail. The first part of that is the pre-visit. That's on the first section here of our workflow, provider workflow for GI Clinic. It's in our first column. The pre-visit is essentially where we are developing our game plan for the patient. We are trying to gather just the key information before we step into the room. Again, assuming this is a standard visit, not an in-depth a second opinion or complicated visit. But for the majority of our visits, probably more than 80 to 90% of the time, it's about a 5-minute process that we will refer to again at the bottom for provider time, where we are trying to confirm we know what the patient is there for, gathering just some key things such as some things off their problem list, probably reviewing their medication list, and certainly clicking on the tab to see if they've seen a GI provider in our office before for some key facts. That in itself should, for the basic visit, take about 5 minutes on estimate. Okay, so that was the pre-visit, again, summarized, taking about 5 minutes of our time for the average patient. We all realize the bulk of the time is with the patient, and this is our next big category of during visit time. And you'll see on our work diagram that that's actually broken up into several categories. And one of the reasons we did that was keeping the 4 habits in mind, realizing some of our providers will want to do that more formalized than others, but using that as the backdrop of investing in the beginning, eliciting the patient's perspective, demonstrating empathy, and then finally investing in the end. Those broad categories are then reiterated throughout this during visit time. So you'll see that that essentially is the longest part of our time with the patient. It should be approximately 15 to 20 minutes, again, realizing those are averages. And this is really the time where in the very beginning, we're asking about investing in the beginning, confirming that you know why the patient is there, making sure that you are trying to outline an agenda for the patient. Many providers commented that they thought that was very important, to be very clear that this is about 15-20 minutes of time, really setting a time limit, especially in some of our more verbose patients. Sometimes that does help keep us on time. The next part is then really getting into some follow-up, getting the patient perspective, and going into some of the detailed questions that are really relevant to whatever the particular problem is, whether it's abdominal pain, whether it's some abnormal labs or some abnormal imaging, getting some of the more of the patient's perspective. Getting some follow-up questions on that next is our further clarification column. Certainly demonstrating empathy as they come up would come up in that column as well, but can be certainly demonstrated throughout on any of these issues. And then finally, towards the end, investing in the end. What does that mean here? Writing the AVS after visit summary with the patient in the room, most providers have found to be most helpful rather than doing it in the back office. That helps as a good summary time to make sure that they are remembering what it is that you have just talked about. So that's a good time to summarize. And then potentially as you're writing some orders, that's a good time to ask the patient to review what it is their understanding is of the next steps, and if they have any other questions. And certainly finally, did they get their questions or concerns all answered in that time frame? That whole during visit time, again, should be about a 15 to 20 minute time frame. Okay, so now that was the discussion of really the most detailed part, the during visit time. The final part is the post-visit. This is where a lot of our providers struggle to have enough time during the day and are taking their work home with them or doing after hours. So this post-visit, again, is the very end where we're doing simple but relevant documentation. This is happening in the office time. Certainly the use of templates is highly encouraged as much as possible, but taking advantage of 5 to 10 minutes of time after the patient visit to document and as much as possible close the encounter is the goal here. Realizing that certain things, variables come up to prevent us from closing the note, such as medical assistant needing to meet with the patient and schedule a procedure. But if at all possible, closing the encounter at this time is advised. If not possible, certainly after the MA is finished with that visit, that's when the encounter would be closed. If you'll see from the beginning to the end, from that pre-visit, all of the during visit, and then the post-visit, that should encompass a full 30 minutes of time. And so if we took about 20 minutes during our actual face-to-face encounter time with the patient and about 5 minutes of documenting, we then lead into the next 5 minutes of pre-visit for the next patient, and so that needs to happen 5 minutes early. So you can see the importance of staying on time, but having these guidelines really help direct us to helping us to stay on time with regards to efficiency with our patients, and I think will lead to higher satisfaction, not just with patients, but also ultimately with our providers, which is our equal goal.